Welcome back to This Explainer. Today, we're diving straight into a medical mystery that hides right in plain sight: high blood pressure. You know, for millions of people out there, getting a hypertension diagnosis, it literally feels like a life sentence. You're told to just take the pills, watch what you eat, and manage it forever. But what if I told you that sometimes high blood pressure isn't actually the disease itself? What if it's just a blaring alarm bell pointing to a hidden, completely curable culprit?
Okay, let's get right into it. For about 5 to 10% of everyone out there with hypertension, we're actually dealing with what medical pros call secondary hypertension. Basically, the high blood pressure is secondary to or caused by some other identifiable condition. And here is the absolute game changer. Because there's a specific trigger, it's often totally reversible. So if we can find that trigger, we aren't just managing symptoms anymore. We're actually talking about a cure.
So let's contrast these two. On one side, we have standard primary or essential hypertension. We don't really know the exact cause, but usually pops up in middle age, and while it responds well enough to standard drugs, you're pretty much stuck with it. It's irreversible. But then look at secondary hypertension. The cause? Identifiable. The patients? Usually either quite young or elderly. It's also notoriously stubborn, meaning it doesn't respond well to standard blood pressure meds. But the massive payoff here is that it's potentially reversible. When routine drugs just aren't cutting it, that's a massive clue that doctors need to dig a little deeper.
Red flags. When to suspect a hidden culprit. Let's look at the specific clues that tip doctors off that they aren't dealing with your run-of-the-mill high blood pressure.
These are rule breakers. Medical detectives know they need to start investigating immediately if a patient gets high blood pressure before age 30. That just shouldn't be happening. We're also on high alert for severe or resistant hypertension, where the pressure refuses to budge even with multiple medications. Other major red flags? A sudden dramatic worsening of blood pressure that used to be stable, or blood pressure that spikes right alongside hypokalemia, which is low potassium in the blood. And finally, malignant or accelerated hypertension, which is a dangerously fast rise in pressure. These are all anomalies. They just do not fit the standard profile.
So, who are we looking for? Let's check out the suspects. Biological rogue agents. The most common culprit behind secondary hypertension comes from the kidneys, specifically renal parenchyma disease, like chronic glomerulonephritis or diabetic nephropathy. Here is how this biological sabotage goes down step by step. First, the diseased kidneys cause the body to hoard sodium and water. You just hold on to way too much fluid. Step 2, this triggers a massive alarm system called RAS, the renin-angiotensin-aldosterone system. Now, RAS normally regulates blood pressure, but here it just goes completely into overdrive. Step 3, this crazy RAS activation cranks up peripheral resistance in the blood vessels, which violently spikes the blood pressure. It's a biological chain reaction that simply refuses to turn off.
But wait, the kidneys can actually be compromised in other ways, especially through their blood supply. We call this renovascular hypertension. This might come from atherosclerosis in older patients or a condition called fibromuscular dysplasia in young females. Doctors are hunting for highly specific clues here, maybe a sudden spike in serum creatinine, which is a kidney function marker, right after the patient takes standard ACE inhibitor drugs. Or they might literally hear an abdominal bruit. That's a distinct swishing sound heard through a stethoscope, caused by turbulent blood flow in a narrowed kidney artery. Another huge tell is recurrent flash pulmonary edema, where fluid just rapidly, suddenly floods the lungs. Okay, if it's not the kidneys, we look at the endocrine lineup. These are our hormonal suspects. First up is primary hyperaldosteronism, better known as Cohen's syndrome. In this scenario, the body is just pumping out excessive amounts of the hormone aldosterone. And let me tell you, this hormone wreaks absolute biological havoc. It literally forces your body to hoard sodium and just dump potassium. The result? Severe sodium retention, major potassium loss, a chemical imbalance known as metabolic alkalosis, and notably low plasma renin activity. And of course, all that excess fluid from the sodium retention causes the blood pressure to absolutely skyrocket.
Now, our second endocrine suspect is incredibly dramatic. It's called a pheochromocytoma. This is a rare, genuinely life-threatening tumor that grows in the adrenal medulla, the inner part of the adrenal gland sitting right on top of the kidneys. The wild thing about this tumor is how it behaves. It dumps massive amounts of catecholamines, which are adrenaline-like hormones, directly into the bloodstream in sudden bursts. Because of these bursts, the symptoms are unmistakable: highly episodic hypertension, intense pounding headaches, profuse sweating, and rapid heart palpitations. Honestly, it mimics a massive panic attack, but it's actually a tumor randomly firing off hormones.
Rounding out our primary endocrine lineup, we have Cushing syndrome. This one is all about excess cortisol production. Cortisol, as you probably know, is our body's main stress hormone. This excess can be endogenous, meaning the body itself is making too much, maybe because of a tumor, or exogenous, meaning it's coming from taking steroid medications. Cortisol essentially acts as a secret hypertensive agent because it has mineralocorticoid effects. Basically, it acts a whole lot like aldosterone, forcing the body to retain sodium and water and driving that blood pressure right through the roof.
And you know, this really highlights just how wide a net these medical detectives have to cast, because the suspect list doesn't end there. Thyroid disorders, both hyper and hypothyroidism, can mess with cardiac output and vascular resistance. Then there's obstructive sleep apnea, a massively underdiagnosed condition that triggers your sympathetic nervous system every single time you stop breathing at night. We've also got congenital issues like coarctation of the aorta. That's a narrowing of the main artery from the heart, which gives you high blood pressure in the arms, but noticeably weak pulses in the legs. And let's not forget everyday drugs. Oral contraceptives, NSAID painkillers, steroids, and even some over-the-counter herbal supplements can absolutely induce secondary hypertension.
All right, so how do we actually catch them? Let's get into the detective tools, catching the culprit. Our first line of defense always starts with an initial laboratory evaluation. Doctors aren't just taking blood blindly here. They're hunting for very precise biochemical footprints. They're checking serum electrolytes, looking for that high sodium or low potassium we just talked about. They check urea and creatinine to see how well the kidneys are working. They'll run fasting blood glucose and a urinalysis. These might seem like simple everyday tests, but they provide those absolutely crucial first clues that separate standard hypertension from a hidden secondary cause.
Once we spot a footprint, well, that's when we bring in the heavy machinery. Hormonal investigations get super targeted. Doctors will calculate the plasma aldosterone-renin ratio to sniff out Conn syndrome. They'll measure serum cortisol for Cushing's or analyze a 24-hour urine collection for those catecholamines to catch that dramatic pheochromocytoma tumor. Once the labs point the way, we visualize the culprit. Imaging studies like a renal ultrasound or a Doppler will check the kidney arteries. A CT or MRI of the adrenal glands can spot hidden tumors. And an echocardiography can reveal structural heart defects like that narrowed aorta. It's this powerful combo of lab medicine and imaging that definitively identifies the root cause, which then guides doctors to either surgical correction or highly targeted pharmacological therapy.
Now for the fun part, solving the case. Okay, you've got the knowledge. You know the clues. Let's step into the doctor's shoes for a second and apply what we've covered in this explainer to a real clinical scenario. Ready? A 25-year-old female presents in the clinic. Her blood pressure is dangerously high at 180/110. Her lab work comes back and her serum potassium level is incredibly low, sitting at 2.8 millimoles per liter. Look closely at the clues here. Young age, severe blood pressure, low potassium. Take a second. What biological rogue agent do you think is at work here?
If you guessed primary hyperaldosteronism or Conn syndrome, you absolutely nailed it. Let's break it down. That onset before age 30, that is our first massive red flag. The severe blood pressure reading is the second. But the absolute dead giveaway is the hypokalemia, that super low potassium of 2.8. It points straight back to our first endocrine suspect, excess aldosterone forcing the body to hoard sodium, dunk potassium, and skyrocket the blood pressure. By piecing this together, you haven't just diagnosed a disease. You've literally found a pathway to potentially cure this 25-year-old woman instead of just slapping a Band-Aid on it and medicating her for the rest of her life.
And that right there perfectly illustrates why this subject is so incredibly fascinating. Secondary hypertension might be uncommon, making up just 5 to 10% of cases, but the impact of finding it is completely life-changing. It's a powerful reminder that in medicine, we always have to question the obvious. So, I want to leave you with this final thought. If your blood pressure, or the blood pressure of someone you love, resists all standard treatment, could the body be hiding a curable culprit? Thanks for exploring this medical mystery with me today in this explainer. Keep asking questions and keep looking beneath the surface.